having a child with heart disease is bad. It can be terrible. It can be terrible for the family. It can be terrible for the child. What we need to make sure, though, is that we as a medical profession or healthcare providers do everything we possibly can to take away all of the other horribleness that goes with any chronic illness. That we do our best to support the whole family and make the experience as good for them as possible.
Welcome to NICU Professionals, a podcast produced exclusively for NICU professionals, with me, Kathryn Whitaker, as your host. I'm the mom of 6 children, including my very own NICU baby. This podcast is produced by Hand to Hold, a national nonprofit dedicated to providing free personalized support, resources, and community before, during, and after a baby's NICU stay. As a NICU professional, you've been well-trained to care for the tiniest and the sickest of babies every day. While a NICU parent's scars are not as visible, those parents are often as fragile as their babies, requiring patience, guidance, and encouragement to ensure that they are mentally, emotionally, and physically prepared to endure the pressure of a NICU stay. NICU Heroes is dedicated to helping NICU professionals like you better understand, support, and nurture the entire NICU family. Well, howdy, y'all. Welcome to the 2024 season of NICU Heroes. We have 10 fantastic, beautifully smart and wise guests all throughout this year, and I'm so excited to bring them all to you. This month, we're focusing, appropriately so, it's February, on the heart. If you're watching YouTube, I'm even wearing my red for Heart Health Awareness Month. So we're really focusing and honing in on the pediatric heart, specifically congenital heart defects. So I found the smartest guy I knew. He is the chief of cardiology at Texas Children's in Houston, but he is from across the pond. And I know that you're going to love our conversation. What I really love about this conversation is, yes, we talk about signs and symptoms and all the things that you need to know about the heart, but we also talk about treating the whole family. We had an amazing conversation, and I can't wait for you to hear it. My guest today is Dr. Daniel Penny. He grew up in Cork, where he obtained his medical degree, and then he did his residency in Dublin, working in several hospitals, including St. James Hospital, the National Children's Hospital, and the National Maternity Hospital. While he was in Dublin, he had the opportunity to meet with the pediatric cardiologist, Dr. Desmond Duff, who had a huge influence on his decision to become a pediatric cardiologist, and we'll talk about that in our interview. He spent some time in both the UK and in Australia practicing in medicine, and then in 2010, he moved to the United States, where he became a professor of pediatrics at Baylor College of Medicine and the chief of cardiology and co-director of the Heart Center at Texas Children's Hospital. And then in November 2023, Dr. Penny was promoted to the title of Executive Co-Director for the Heart Center. He has led a number of projects, most of which help build healthier lives for children with heart disease globally, with one of the most significant being in Vietnam. He and his wife, a nurse anesthetist, have 2 daughters in their late 20s living in Australia, and I know that you're going to love our conversation. So with that, let's chat. Well, I am excited to have the real expert in the room, Dr. Penny, here with me today to talk about congenital heart defects. So, Dr. Penny, thanks for being here.
Hi, Kathryn. Thank you so much for involving me. I'm really looking forward to the next hour or so as we chat more.
Well, I know you are a super fan of hearts, specifically the pediatric heart, but I'm curious. Normally I'm used to people saying how fun my Texas accent is, but you have a way more fun accent than I do. So I'm curious how it is that you got from the UK all the way over to the United States. So I'd be curious to know how that happened and what led you here.
Yeah, I have to. I'm originally from Ireland, and in terms of accents, I have to go back there maybe once a year to top up my accent. But yeah, I've traveled really and worked in many different places in the world. So I grew up in Cork, and then I did my med-peds training in Dublin. And at that stage, I knew I wanted to be a pediatrician. And I really got to meet a very inspiring pediatric cardiologist, a guy called Des Duff. And it sounds pretty sort of juvenile, but when I got to work with him and get to see how he related to patients and how logical his thought processes were, I decided that, yes, I want to be a pediatric cardiologist. So I then moved to London, to the hospital in London called the Brompton Hospital, which at that time was really maybe the academic hub for the care of pediatric cardiology patients in Europe. And while I was working there and completing my training, then the group in Australia really started to produce outcomes and data that were exceptional. So in other words, operations that had a 30% mortality all over the world, they were reporting mortality rates of 1%, for example. And so
Wow.
they really moved the goalpost. And I felt, well, if I'm going to be doing this for the next, I don't know how many years, I really need to go and see what they're doing. And so I went and I effectively retrained. Then I went back as an attending to London, to the Brompton Hospital, Great Ormond Street Hospital. Then I went back to Melbourne as the chief of cardiology. Then what happened was in 2009, I got a call from Baylor College of Medicine, Texas Children's Hospital. And for somebody who visited the United States, I always felt that Texas Children's was, for me, the definitive children's hospital. Mm. They had vision, they had imagination, they wanted to do cool things. And so I was really honored to be interviewed here. And ultimately, I now have been here for about almost 14 years. Yes, so a mixed up accent indeed.
Well, we're happy to have you here. I'm curious, you mentioned that it was a mentor of yours that helped you fall in love with the pediatric heart. What was it, Dr. Penny, that was so intriguing to you? I mean, there are lots of pediatric organs in a body, but what was it about the heart that intrigued you so much to make that, I mean, essentially your life's work?
Yeah. Well, for me, the physiology of the heart is pretty logical. There are not very many crazy things or unexpected things that occurred. So being a simple man, I think I was able to get my head around a lot of the physiology. But I then started to realize as I was working more in the field of pediatric cardiology, and really as a result of seeing how this particular doctor carried himself, I realized that really the physiology and the operations and the cardiac catheters was really just base camp. This was just the start of what we should be doing for our patients. You know, once you hear that your child has a heart problem, you're suddenly sort of thrown into this world that many people never even knew existed. You know, heart disease is something that happens grandpa and grandma, not my little baby.
Right.
And so it's clear that these families are completely thrown by the diagnosis, and they really need people to walk hand in hand with them and guide them through what can be an absolutely horrible journey. Some people would call it a war. And so for me, that's what I found so fascinating about what we do in pediatric cardiology and in pediatric cardiac care. Some cool physiology, no doubt, some amazing machines that go bing. But also on top of that, for me, was that the rawness, the emotion, the impact of these conditions on children and on their families. And I felt that really this was a good opportunity for me to try and make a difference.
Well, I think when you fall in love with specific organ, whatever it is that your passion is in, but then when you marry that with your love of kids, I think we are the beneficiaries of having people care for our babies and give us good advice on how to move forward because you care about the totality of the person in front of you. So I think that whatever the organ is, if you have that second piece of it, this desire to treat the whole person, it can make such a difference for families. I'm curious because I know you mentioned that sometimes we hear heart disease. I mean, February is Heart Health Month. We hear a lot about it, women's heart disease, men's heart disease, but we don't often think about congenital heart defects and particularly in neonates, so babies who are born early. What makes neonates and babies so susceptible to congenital heart defects different from just the general population?
Yeah. So, congenital heart disease relates to, as many of your listeners would be aware, relates to conditions of the heart that are already present at birth. And so the heart is a pretty complex organ in its development. And frankly, we as yet still don't have all the answers about why your heart and hopefully my heart turned out normal. And so it's even more difficult then for us to try and figure out why some children, why their hearts develop in an abnormal fashion. There's no doubt that genetics plays a role. It's not as strong a genetic relationship, though, as other conditions, for example, cystic fibrosis or things like that. We know that if there is one child in a family who has a heart problem, then a subsequent baby, their little brother or sister, is more likely to have a heart problem than the average children in the community, but it's not dramatically increased like conditions such as cystic fibrosis. But we're now learning a lot more since the Human Genome Project, since some of the work on stem cells. We are now really able to find some of the keys to why some children appear to have abnormally developed hearts. Then there are some children, for example, with conditions such as Down syndrome or trisomy 18, and they have a very high risk of cardiovascular disease. And so there's still a lot of work needs to be done. Every year we are unraveling or uncovering new causes for cardiovascular disease in children, particularly in the arena of genetics, so that, in the past we had the obvious child, say, with Down syndrome, an obvious abnormality of their chromosomal abnormality or genetic abnormality. It was fairly straightforward to recognize the association between those and cardiovascular disease, but now we're finding much more subtle abnormalities of genetics in children who formerly we would have felt had just spontaneously occurring cardiovascular disease, and we really had no causation.
Well, I mean, it feels like the organ that I guess continues to teach us. Just when you think, oh, I think we have this figured out, then you look up and you're like, oh, I didn't even think about that particular thing.
Yeah.
I think we had never, I knew about heart disease, but it wasn't until we had our own NICU baby who was born with both a VSD and a PDA that I felt like we had opened a whole new door to the wing of the house that I didn't know existed.
Yes.
So maybe Dr. Penny, walk us through. I know PDAs tend to be a common neonate condition that babies are born with. So maybe let's walk people through what is a PDA and what are some of the symptoms of that, and how does that differ from things like a VSD or even HLHS, which is hypoplastic left heart syndrome for people that are listening. So kind of give us an idea of some of the things that you would be evaluating when you're looking at a baby, trying to figure out what would be some of the early signs that they have something going on with their heart, and then how do you diagnose what it actually is?
Sure. So I think, Kathryn, one important principle is that for the majority of children with congenital heart disease, they seem to present at times when major changes in their normal perinatal transition, physiological transition, is occurring. What do I mean by that? Well, before a baby's born, they obviously are not using their lungs, and so they will have a high resistance to flow in their pulmonary arteries. They will have bypass channels that are present in the heart, the foramen ovale, or in the great vessels, the ductus arteriosus. And then what happens in the very early days after birth, these bypass channels, as the baby starts to breathe for themselves, these bypass channels tend to close off. And then children will present with conditions, for example, where these bypass channels have been necessary in order to maintain the circulation. To give you an example, coarctation of the aorta, a condition in which the aorta is obstructed. Babies can do very well with coarctation in the aorta before they are born because they have a ductus arteriosus bypassing the obstruction. You can then see that when that baby is born and the ductus arteriosus starts to close down, then they will become symptomatic. More complicated condition that you described, hypoplastic left heart syndrome. Again, what happens is that the left side of the heart is underdeveloped, but the circulation can accommodate that problem because the foramen ovale, or the atrial septum, is open. And so blood coming back into the left side of the heart can cross the atrial septum, then go into the right side of the heart, cross the ductus arteriosus, and this baby will be pretty well for 9 months. But then they are born and the foramen ovale, or the atrial septum, starts to close. And suddenly they're now critically unwell. Their ductus arteriosus closes. And then the other thing, as I was saying, that reduces the amount of blood flow to the lungs is the very high resistance to the lung blood vessels. And usually what happens is that over the early weeks and even months after birth, this resistance gradually falls. And so then what happens is that if you have a ventricular septal defect, for example, that you referred to earlier on, then what can happen is that as the resistance to the lung blood vessels falls, more blood will flow into the lungs, and the little baby will become more symptomatic. And so for that reason, a lot of babies, at least formally, would be discharged as being apparently well from the maternity hospital, who then come back to us a few days or even a few weeks or even a few months later with symptomatic congenital heart disease. The first thing the families always ask is, how was this missed?
Yes, yes.
But this is the reason, is that they still have this transitional circulation that I talked about that is able to compensate, and it's only when the baby goes through those transitions and hits important milestones that they then become symptomatic. Does that make sense?
As a matter of fact, I was just getting ready to say that makes so much sense, because it felt like, Dr. Penny, as we were in the hospital and like one more thing, we would uncover one more thing. And I'm like, how are we missing this? Like, couldn't we have seen this, weeks ago? But now that you're saying it that way, that our body is such a complex, intricate little orchestra of all these different organs working together. And as they grow and get bigger, some of those instruments don't talk to each other, and then you start to see how they come about. That makes actually a ton of sense, because I think a lot of parents may be thinking, how did we miss this? These are educated, well-informed doctors. How are we missing some of these things? But that makes a lot of sense.
Yeah, and even things like, with respect to a ventricular septal defect in a very, very young baby, in day 1 or day 2 after they're born, you often may not even hear a heart murmur, because the murmur reflects turbulence of the blood flowing across the ventricular septal defect. And if the resistance in the lung blood vessels is very high, A, there's not going to be a lot of blood flowing across, and B, there won't be a big pressure difference between the right and the left side, and so there won't be turbulence. And so parents are often confused. Hang on, another doctor listened to Johnny's heart when he was a day old and said everything was fine. Yeah. How are you now telling me that Johnny has a loud heart murmur? And that's the reason.
No, it absolutely makes a lot of sense. We used to joke that our son had a medical student murmur, that even a medical student could hear it. And at the time it made me really nervous, because our minds tell us the louder the murmur, the more serious the condition. And what our cardiologist was reminding, he said, remember, is that pressure that he was talking about. He said, it's actually getting better. Just hang in there. Yeah. And then Fortunately, it wasn't the case with both of his defects, but the VSD repaired on its own. And, as it would get louder, I mean, he said, even you can hear it. And I would put the stethoscope in and say, yep, I can hear that. So, but yeah, I mean, I think our default is to think that the bigger the sound or whatever, that surely that means that the bigger the problem. But when you say it that way, it makes sense.
And so for us, if we see a child who on an echocardiogram has a decent sized ventricular septal defect, say at the age of 3 or 4 months, and we don't hear a loud murmur, then we're much more worried than if we do hear a loud murmur.
Right. Which seems sometimes counterintuitive, but I understand what you're saying. So what would be some of the other things, Dr. Penny, as a parent, is navigating a heart defect that might be something that they would say, oh, that's concerning. Like I know that sometimes, like we would notice sometimes when we would feed our baby that he would turn blue. Obviously that's bad. So I know that there may be some other things that parents might see in their baby that say, oh, maybe I can tell that their heart's working really hard and it shouldn't be having to work that hard. What might some of those symptoms be for some of those parents?
Yeah. So when people like of my age have heart problems, then we typically have issues exercising. So your baby's biggest exercise is when they're feeding. And so if your baby is every time that they're feeding, they're pulling away from the bottle or the nipple and they seem to be breathing very quickly, that's a sign that things aren't right. And then as a result of that, and the fact that because they're breathing so quickly, they're metabolizing a lot, they're using a lot of energy, then they will fail to thrive. They won't grow as well as another child.
Right.
Some children get very odd episodes of sort of, if you have an arrhythmia, in other words, an episode of collapse, obviously everybody would realize that that's not something that you should ignore. And as you said, cyanotic or blue episodes are also something that are very important that we don't ignore. And, a lot of those would be an indication to either dial 911 or go to your emergency room. But yeah, these are the typical symptoms. But it's also important to know that a lot of children that we see have pretty significant heart disease and they're completely asymptomatic. And this can be very, very difficult for parents, because we're then in the situation where we're suggesting to a parent that we need to do a heart operation.
Right.
And they say, well, I wouldn't have even known about this unless Johnny had the echo. And then that involves an additional stress for the family, additional concern, and self-doubt that we really need to be very aware of. Obviously, if you have a baby in front of you who is unwell and a doctor says, I think that we should do something surgically or in the cath lab, I think that most people would accept that. We do sometimes see children, however, who are well, and then that's an additional challenge for those parents.
Right.
And we're doing these procedures as a sort of an investment for the future, because we know that if we wait for the baby or the child to become symptomatic, then we've sort of dropped the ball, as it were.
Right.
And it's too late. And so that's the reason why there's often this discordance between a baby's symptoms and the decision for us to do a procedure.
Sure, because when a baby or really any of us clinically look like we're doing okay, it's really hard to say, but how is it that the internal part is not matching the external part?
Yes,
so
exactly.
I do think that gives us sort of a pause and a reminder that sometimes the things that are challenged, we can't always see them. Like you have to dig under the surface a little bit to figure out what's going on. I'm curious. So that actually leads beautifully into my next question, Dr. Penny. If you have a parent or a family who has just found out that their child has some sort of congenital heart defect, and they're really struggling, one, to understand it, but also thinking, what is the quality of life of my baby going to be like long term? How do you help parents, one, understand the condition, and two, understand this is what your child has to look forward to as we look forward to their quality of life? How do you help parents sort of come to terms with both of those things?
Yes, thanks, Kathryn. So basically, I see that I have a number of jobs here. One of my jobs is obviously to explain the anatomy and physiology and the operations, et cetera, et cetera. But again, that's just a little piece of it. There's also the emotional aspect, the mourning that our families go into. Oftentimes they're mourning for a perfectly healthy little baby who ultimately will get there, but may take some time.
Right.
I think that an important thing for me to do up front is to acknowledge to the parents that we're actually looking at this problem through different windows, as it were. By that I mean is, on the one hand, I want that family to know that this is something that I am not going to lose any sleep over. But that doesn't mean, but I have to say that while not undermining or discounting that they're looking at this whole problem through a different window. Right. And so they need, and so I typically say to parents, we can manage this. I'm very confident that we can manage this. So I'm not worried about Mary or Johnny. On the other hand, I'm the same person who, when his daughters had their ears pierced, I freaked out. And so I think that that's trying to acknowledge that we're actually looking at this through different windows is really important, because on the one hand, I can say, oh, look, this is just a VSD, forget about it. But you're not going to forget about it. Right. This is terrifying for a parent. On the other hand, I can't go into this terror mode that often parents go through, because frankly, they do need somebody who's going to have the confidence to hold their hand and walk through them on this journey with them. And so that's a very important job that I think that we have to do.
Yeah, I think this ability to understand that everyone may see the same problem, but they don't see it the same way.
Yeah. And so I've been in this situation where I've been on the other side of the fence, as it were, with a loved one with a serious medical condition. And frankly, I wish that some of the physicians didn't really belittle what we were going through, and saying to me or saying to us, oh, this is going to be a walk in the park, when it wasn't a walk in the park. I would have preferred to have known. For them, it was a walk in the park, but not for me.
Right. I think the acknowledgement that you may have treated hundreds, maybe thousands of a particular kind of heart defect, but this is that family's only one, or maybe their second one. And so it's obviously personal, but every situation is unique, and what their support system may look like, or what their access to care may look like, is very different. And so I think recognizing that it's probably a good reminder to all of us that when we encounter something that feels familiar to us, remembering that it may not be as familiar to the person that we're speaking to, and maybe looking at it through a different lens is a good perspective. So you did something really cool. It's fun when I love going on YouTube and finding out all the cool things that people do, but y'all did a really fun thing at Texas Children's. So you have this whole heart animation series. So I know we're talking a little bit about how complicated the heart is and how you're uncovering new things as years go by. But most of your patients, I know some of them may be neonates, so maybe not fully understanding what's going on. But as they get older and they realize, oh, I have this condition with my heart, but I don't fully understand it. And then maybe you have parents who may not understand it either. And then y'all started this really cool program that teaches the heart and what's going on, but in a very fun and I think engaging way. I would love for you to tell people about the heart animation series that y'all have done at Texas Children. It's awesome.
Thanks, Kathryn. Yeah, so one of the problems that we have in pediatric cardiology is that we see lots of children. We ask them to do things and to take their medicine and to take a deep breath and to lie still for an echocardiogram, et cetera, et cetera. Right. Problem is, though, is that oftentimes many of those children don't even know why they're in the room with you. Pediatricians often talk to the parents and they don't talk well to the child. And so then we're wondering, well, why isn't this child sort of doing what I ask of them? Why is this child crying during an echocardiogram, whereby we all know it's perfectly painless and harmless, and what's going on? And so it's been well shown now that if you ask children what would help them to get through their illness, it's about age-appropriate knowledge. And actually, when you ask the parents, that's also they will answer the same. They will give the same answer. And so information is important. It's not just being nice, it's purposeful. We know that if you can explain to a child and to a family what the condition is, what they are, not just the anatomy and physiology, but what they're likely to go through as being a child with congenital heart disease or a parent of a child with congenital heart disease, then their confidence in the system improves, their level of stress is reduced, and their outcomes are better. And so this is why we did these little animations for children. It was quite fun actually doing them. And, the learning is just an aside. It's all these sort of adventures of these characters. I started doing these in Australia, actually, and it was quite fun. I had a group of children, my expert panel.
I love it.
And we would sit there for ages, writing scripts and developing scripts. And then I would say something, oh, maybe he's going to say this. And they'd say, Dan, don't be ridiculous. He would never say something like that. So that was fun for me. What we're now doing is we have been doing another series for grown-up children, older children, and for adults. Again, using detailed animations of most of the cardiovascular congenital abnormalities of the heart. We're going to be releasing some of those shortly. And it's a slightly different, it's more technical, but again, I hope that when they come out, you'll get to look at them, Kathryn, and enjoy those as well. Yeah. I think what's also important, something that we've been trying to do here, though, is as well as teaching people about the anatomy and the physiology and the surgery of the congenital heart disease, we're also trying to discuss with families what it's like to have a child with congenital heart disease. Mm. It's relatively easy to find on the internet what the arterial switch operation is. It's not as easy to find on the internet how do you help yourself when you hand over your child to an anesthesiologist for your child's arterial switch operation? Or how do you look after yourself and look after your partner when your child is on the intensive care unit after having the arterial switch operation? And so again, that's something that we're actively working on, because frankly, the plumbing and the sutures and the operations are really just the beginning of all this. There's a lot more we can do.
I'm really glad that you mentioned that. I do think it's worth mentioning. The videos are very cute. They have a bison and an armadillo, very Texas on brand of explaining. Yeah, I know. I love it. Using racetracks and showing kids, the red and the blue. I loved it. But I think that you're right that I think it feels easier to understand the plumbing, as you say, and to understand the process, because the alternative of what do we do after feels so much harder, Dr. Penny. And as a parent, one, you don't want your child to suffer, but secondly, you're also always concerned of what is their quality of life going to be like and how can I support them? And that is such an unknown, and it feels very overwhelming. And your child may have even more, like, yes, they may have a congenital heart defect, but they may have other specialists as well. So this may be on top of other things, and it feels like a lot. Like, how are we going to navigate this, and how do we find support and be at peace with where we are, with knowing there are some unknowns, but I'm grateful that you haven't forgotten that second piece. The plumbing is important and understanding that, but I'm grateful that you haven't forgotten the second piece. What a gift to families that will be. This podcast is produced by Hand to Hold, a national nonprofit but we're more than simply a podcast. Hand to Hold is here to support your NICU in two ways. One, you can refer your NICU parents to us for support, or two, you can bring dedicated Hand to Hold support to your NICU, either in person or virtually. Our support consists of one-to-one group and educational resources, including our family-focused podcast, NICU Babies Parent Support. For more information, visit handtohold.org and click on NICU Professionals.
And in terms of outcomes, the vast majority of our patients now have spectacular outcomes.
Has that changed, Dr. Penny, since you started in cardiology?
Quite dramatically. Yeah. And I'm chairing a session at a conference in a few days, actually, speaking to adults with congenital heart disease on some of their experiences. Some of those are pretty famous physicians, actually. There are some pretty famous athletes around the United States who have had pretty serious congenital heart disease. And so in terms of outcome and ability and quality of life, I think that we have turned through 180 degrees over the last couple of decades or a decade or so in terms of how we think about this. When I was a fellow and a student, we had to learn off these long lists. In this condition, they shouldn't exercise. In that condition, they should do modest exercise, et cetera, et cetera, et cetera, et cetera. So in other words, we sort of beat ourselves to learn the things that a patient with congenital heart disease can't achieve. And we sit there with our parents, and we also convince the parents of all of those things that their child can't achieve. We have now turned through 180 degrees, and we are now much more interested in showing patients, showing their parents exactly what their child can achieve. We do a lot of work on rehabilitation, where we have in our heart center, we have 2 rehabilitation gyms, for example, whereby we can show parents and show children, actually, you can do a lot more than you think you can do. And I think that is very invigorating for them. It's very empowering for them. And as I say, I have friends who are pediatric cardiologists who've had and pediatric cardiac surgeons who've had very, very complex congenital heart disease themselves, who you wouldn't know unless they actually told you. And so a revolution has occurred, and that revolution is going to continue.
I'm reminded as you say that, my son, I mentioned earlier that he had a VSD. And I think in the early days, we heard from a lot of specialists. So these are the things that he cannot do, or these are the things that he's going to be limited by. But I'll never forget, we went to his pediatrician. This was a few years later. And we were going through all of his history. And his pediatrician opened up the top of his shirt and showed his scar. And he said, "Hey, buddy, that's my VSD scar." And it was so, our son's eyes lit up. And I thought, I don't think that I ever thought that could be a possibility. Like, what a witness to be like, hey, I'm just like you. And, here I am. And it was such a gift to him. And certainly I think to all of his other patients, that what you can do, like, there are so many, and it's not the plan B, but like, these are things that you have to look forward to. And it was such a powerful moment. In fact, when you said that, I was reminded of what a beautiful moment that was.
Yeah, that is beautiful.
Yeah.
And the other things too is that we need to, as parents, need to work very closely with their pediatric cardiologists and their pediatricians in order to try and explore those possibilities. Because oftentimes we're in the situation in which, a parent hears that their child has a heart problem, and then they are overly protective.
Yes.
And as a result of that, you will have a little child who has a relatively minor congenital heart abnormality, who is not able to have a proper childhood. They're not, allowed to play sports, or mix with friends or things like that.
Right.
And so again, it's very important that we don't just go into this sort of negative mode. Pediatric cardiologists and pediatricians are very good at telling people or working with people about the activity levels that could be expected depending on the congenital heart disease. But we also need to make sure that we balance any restrictions with not making the childhood miserable, as it were, and allowing them to be what they can be.
Finding the joy of childhood while also remembering
Exactly.
that they have a condition that needs to be treated, but not stealing away moments of their childhood that they could have just because we were afraid. I'm curious, Dr. Penny, I know you talked a little bit about how much the care has changed in pediatric cardiology when you started. Like, what do you think in the last decade or so, what have been some of the biggest advancements in pediatric care when it comes to cardiology and how you treat patients?
Yeah, so there are quite a lot of technical advances. A lot of those are transcatheter procedures. So in other words, a lot of children now with atrial septal defects, children with patent ductus arteriosus, and even more complex disease can now be treated in the cath lab rather than having the scar on the chest like your pediatrician has. And we're making a lot of advances in those areas, implanting valves now through transcatheter procedures, doing a lot of arrhythmia therapies. We are more aggressive with transcatheter approaches to arrhythmia therapies than we used to in the past. In other words, we had a lot of children on a lot of pretty complicated medicines that they were taking 3 or 4 times a day for many years. Whereas now we know in the cath lab, we can treat those arrhythmias using radiofrequency or other procedures that will really mean that the patient no longer needs to take the medication. So that's truly revolutionary. Our surgeons are now much better at preserving the heart function during operations. They're much more accurate. So that you can have on paper the same operation that was done 20 years ago to now, but actually from a surgeon's point of view, it's quite different. And as a result of that, the outcomes are likely to be a lot different in terms of preserving the cardiac function, et cetera, et cetera. The idea, the use of bridge to transplantation using ventricular assist devices is, again, truly inspiring and truly revolutionary. And what this means is that these children, the very sad thing in transplantation medicine is that you may have a child waiting on a transplant waiting list. No donor organ becomes available. The child passes away, and then sadly, the ideal organ became available 2 weeks later. And that's horrible. And so if you can preserve the child's life for longer, then you are likely to lose fewer of them under those sorts of circumstances. And this is why now we have done a lot of work in ventricular assist devices here at Texas Children's Hospital in order to try and prolong life for patients on the transplant waiting list. And what's ironic or fortuitous is probably a better word, is that we started off putting children on ventricular assist devices in the hope of buying this extra time. And then we found that some of our children were really well on these ventricular assist devices. And indeed, they didn't want to have a cardiac transplant. And so you can see that as these technologies continue to develop, they are going to be used more and more as almost destination therapy. You could almost see, for example, a child could go on a ventricular assist device as a bridge to transplant. They would then have their cardiac transplant. They may need another cardiac transplant. But then ultimately their next therapy could be another longer term ventricular assist device. And so it's not just buying a little bit of time with the VAD nowadays. We have a much more mature way of looking at ventricular assist devices in patients. But then above and beyond all of that, the technologies of what we do, I think our insights into the way in which our teams operate. And so we now realize that it's not just some famous cardiologist or famous cardiac surgeon who's going to save your child's life in a heroic fashion. That cardiologist and cardiac surgeon is part of a wider treating team. Doctors, nurses, physical therapists, speech therapists, psychologists, therapy dogs. And so this idea of the respect and showing that the team can actually do a lot more than an individual can is also something that has really revolutionized the care. It's reduced the stress of some of these conditions on parents. It reduces, and their children, it reduces the number of children who have long-term PTSD type syndromes after some of the complex procedures that we do.
Well, I know when we were like in the NICU, this idea of family-centered care, in other words, a team approach, things were not so segmented. So instead of hearing from one day and another day, instead we all heard the same thing. And I think, yes. I know you're a big fan of the team environment, that it does help overall, not just the health of the patient, but I think everyone's stake in how well the patient does, because you're all hearing and seeing the same things, but you're also, like, I remember sometimes people would say things and they would never have said it in that setting. They would never have heard it that way had they not been present in that setting. And so it was sort of revolutionary in the care. And that was, more than a decade ago. I know there are more hospitals that have that approach, but it's encouraging though to hear, Dr. Penny, that it's not just happening in the NICU, but instead it's happening in other areas of the hospital, that we stopped being so segmented and started being more team-based.
Absolutely. And so there's much more collaboration within teams and also between teams. Right. Between the NICU team and the cardiology team, between the cardiology team and rheumatology, for example. I was very proud, for example, during COVID. So in other words, we all heard on a Saturday evening about this new mysterious illness that was coming in children who had COVID, like Kawasaki type disease, a systemic inflammatory response. What I was proud about, though, was that by the middle of the following week, by the Monday or Tuesday, so just 2 or 3 days afterwards, we already had our multidisciplinary team in place and our protocols developed involving cardiology, rheumatology, pulmonology, critical care. And we already had all of our protocols developed, and we had run through some scenarios before we even had a proper name for the condition, and even before we had ever seen a patient. Wow. And so we could not have done that 20 years ago. And I think that this sort of humility, I guess, collegiality, putting them all together in a team that we're all fighting the same enemy, I think that when we do that, we can really do remarkable things.
I think you're right. I'm thinking back to the synergy of a team, how that changes. No one wins a sporting event individually. There's a lot of people that play a role in that, whether they were the nutritionist that fed the athlete or the mom who loved them there, but that we're all part of this bigger system. We were meant to be dependent upon one another. I'm glad that you mentioned that.
It's the day after Super Bowl day, and we on Super Bowl last night, they had a lot of the parents and big sisters of a lot of the players. And so while these players are our heroes, there's a whole machine of love behind them.
I love that. That's a good way to say it, a machine of love. I love that. Oh, that's good. I'm glad that you mentioned transplant, Dr. Penny. I'd love to ask you a few questions about that. I know that some, like you said, some congenital heart defects can be treated either through medication, lifestyle, maybe surgeries, but then some require a new heart. And I know that largely is dependent upon the critical nature of the child, the condition it is that they have, but what I guess leads you to a point where you're like, we must do a heart transplant, and then what does quality of care and quality of life look like after that? I know you mentioned that some patients might even be a candidate for a second heart transplant, depending upon where they are. So maybe walk us through the transplant process and how that can affect a family.
Yeah. So again, the word transplant is a shocking word for families, isn't it?
Yes.
And so again, we need to make sure that we talk about this not in a sort of a sudden meeting, but we just gradually work up to that. Where, usually, transplantation, obviously we all like, the desired outcome is for the child to go for the next 85 or 100 years with their own heart in place.
Right.
Oftentimes, though, with that great desire that we have, we sometimes may push things too far. Mm. And then when their cardiovascular disease impacts on their renal function and liver function, et cetera, then we're on a sort of a losing strategy. And so we have a whole team of experts here and we're always looking for those indicators about when, we're not likely to get any further gains by leaving the child's own heart in place. Our outcomes now for cardiac transplantation are many, many, many times better than they were before. And oftentimes you must remember is that these children are not just children, usually children coming in off the street. They've already been at quite complex procedures done, complex medical therapies, et cetera, et cetera. Yep. Again, though, it's one of these extreme team sports is it may be an offensive term, but I think you know what I mean. Mm-hmm. I think that it is essential that everybody is on their game. Mm-hmm. Both from the point of view of the physiology, but also the psychology, the social support systems, et cetera, the coordination, and the long-term follow-up. And so all of our patients with cardiac transplantation require lifelong follow-up, that require lifelong medications, recurring visits to hospital. It's very important that we make all of our parents and children, to the extent they can, aware of that. And so they are a very special group of patients. They're a very inspiring group of patients. And the teams that we have looking after these children and their families are equally inspiring. It's a lifelong journey, and the bravery that these families show is really very humbling for somebody like me.
In our parent podcast, we did an interview with a family. Their son has HLHS. And when I spoke to her, they were pre-transplant. He was on the transplant list. And a few months later, he received a heart. And so I'll be interviewing her later this year. But it's been really beautiful to see their experience. But she always acknowledges the donor heart. And she said, our joy was also someone's hardest day.
Yes.
And so I think that is the decision, as a team of people, that you have to make this decision, but also knowing that it comes at a cost. And so how are you good stewards of this heart that you've received, and how can it, prolong the life and give them a beautiful life? But there's always, she said, it's a little bittersweet, because she's always reminded with every heartbeat, she knows what that could be on the other side. So, transplant is a fascinating process, and knowing that some of those kids have opportunities to live that they would not otherwise have had 10, 15, 20 years ago. So I just wanted to touch on that. I thought it was important.
There's a very famous musician, I don't want to name him by name, but he's had a heart transplant, and he gives a talk. And while he was he had congenital heart disease, while he was waiting for his heart transplant, his brother died traumatically. And so that, so he was in the situation where he had, his family were working through all of the mixed emotions of his brother being a donor for another family, while at the same time he was waiting for something similar to happen to another family so that he could live, is how he puts it. And so, they are emotions that I can't even fathom.
Well, I do believe that there are so many steps that you can take before you get to transplant, that, like you said, that there are lots of things, many steps to get to before you get to that stage. But I'm curious, I know I just have a few minutes left with you, but I'm curious, I always love to hear a little bit about how you want to dream. So I'm curious, Dr. Penny, over the next 10 or 15 years in cardiology, particularly pediatric cardiology, what's your hope for the outcomes and the way that we treat patients, and advances that we make in medicine? What's your dream in the next 10 or 15 years?
Yeah. Well, I believe that we will necessarily improve some of the technological advances that we described. I'm assuming that, ventricular assist devices, for example, will continue to evolve and continue to develop. Some of our transcatheter procedures will continue to develop. For me, the two things that I would really like for us to see in our specialty are, firstly, a lot more attention to what we described earlier, patient and family experience. In other words, having a child with heart disease is bad. It can be terrible. It can be terrible for the family. It can be terrible for the child. What we need to make sure, though, is that we as a medical profession or healthcare providers do everything we possibly can to take away all of the other horribleness that goes with any chronic illness. That we do our best to support the whole family and make the experience as good for them as possible. The second thing that I would like to, given that we're dreaming here, is I really believe that I hope that we can democratize the care for cardiovascular disease across the world better. In other words, you talked about ventricular septal defects. If you need an operation for a ventricular septal defect, that is a traumatic event for the family. But they will come in, the child will have the surgery, they will go home after a few days and then potentially live till they're 105. That's not true for 90% of the world. It's estimated that about 90% of the children born with congenital heart disease have no access to even the most basic of care.
Wow.
And so for me, as somebody who dreams about a better future, that is something that I really would love for us to improve on.
I agree. I share the same dream, Dr. Penny. Thank you for your life's work, really, of caring for pediatric cardiac patients. I know that our family was eternally blessed by all the cardiologists and cardiothoracic surgeons that worked with not only our kids, but families that we knew intimately. And it is a gift, I think, to be able to interact together on a team. And so I'm grateful for the work that y'all do at Texas Children's, but also for telling people what all is possible and how we can love our patients and serve them better. Thanks, y'all, so much for listening. That was a fantastic conversation. I hope that you'll do me a favor. If you love today's episode, please share it with a friend. You can also review over on Apple Podcast or Spotify or wherever it is that you listen to podcasts. You can also give us a listen and a watch over on YouTube. It's how we reach more NICU professionals. Today's podcast episode is sponsored by Reckitt Mead Johnson, whose mission is to nourish the world's children for the best start in life. For more than a century, they have led the way in developing safe, high-quality, innovative nutrition products and continue to push the boundaries of nutritional knowledge with consistent, strong investments in scientific exploration.